Start, sir. We are learning.
Good evening and welcome everyone. I would like to invite you to the webinar which is under the Aegis of Cancer Research and Static Foundation. The name is Breast Cancer Conclave and the convener is Dr. Jatin Sadin sir, who is the Director, Department of Medical Oncology, IBY Hospital, Mohali. And I would like to invite Dr. Jatin sir to take further proceeding. Over to you, sir.
Thank you, Ankit, and thank you, AstraZeneca, Medgenome, Cipla, for being supportive and for this particular meeting. And we are going to concentrate on HR positive and HER2 new positive tumor breast cancer today. A major chunk is TNBC, but we'll deal with that in a separate meeting. So, in HR positive CDK4/6 inhibitor have taken the breast cancer scenario by storm, and in HER2 new positive breast cancer, uh, we have all kinds of newer antibody drug conjugates, and now a new entity is there, which is HER2 low. So it will be an interesting discussion. So I would like to invite the chairperson, sir, for today's webinar, and that is Dr. H.P. Singh. He is a very senior medical oncologist, presently working at Paras Hospital, Panchkula. Over to you, sir. Ankit, Dr. H.P. Singh is there.
Yes, sir, he is there, sir.
Hmm.
Technical team, can you check is the sir mute or what?
Sir, you are muted.
Okay, can you hear me now?
Yeah.
Yes, sir.
Okay. So I'm thankful Dr. Jatin Sareen for organizing this conference. I would like to welcome our first speaker, Madam Kanika. All of us know her very well. She's both a radiation and medical oncologist and expert even in genetics. She's going to introduce us to a new concept about HER2 low breast cancer, especially in light of Destiny 4 trial. So I would request Madam Kanika to kindly educate us and let us know what more deeper in, knowledge we should have before we start practicing it in our actual practice of oncology. Here, over to you, ma'am.
Thank you so much, sir, for the warm welcome. And thank you for the organizing committee for inviting me and including me in this discussion. So is my screen visible?
Yes, ma'am.
Okay. So good evening, everyone. And I'm Dr. Kanika Sharma from Max Hospital, Mohali. Today, I'll be discussing about a subset of breast cancer that is HER2 low and how it has now changed the way we actually diagnose breast cancer and in the further treatment also. So, as we all know that it is a heterogeneous disease and breast cancer is not a single entity. So, when we even explain to the patients, we tell them that the biopsy is needed to further classify the type of the breast cancer. So, when a new patient comes to our OPD, so as we all know from the data that it is the most common cancer and the second leading cause of death among all cancer in the females, and around more than 5 lakh women, they were diagnosed with breast cancer in Europe in 2020. And the data is even worse in the Indian setup. And when we talk about the biomarker setting, as we all know from the baseline only, there are almost 3 tests that we universally do, that is the ER, PR, and HER2 testing upon the primary diagnosis. And in the metastatic settings, if the interval is very high and the DFI is very high, so we do a repeat biopsy also to reassess these biomarkers in the recurrent setting. So based on the reports of this ER/PR HER2/neu, we do a molecular subtyping of the tumor to see whether it is luminal A, that is ER/PR positive HER2 negative with Ki-67 of less than 14, or a luminal B, that is again can be HER2 plus or minus with a Ki-67 of more than 14, HER2 positive subset, or a basal or a TNBC subset. So treatment selection is actually guided by what molecular subtype of breast cancer the patient has. So when we talk about HER2, till now, we used to see the report as HER2 positive or HER2 negative. So when we talk about at the molecular level, HER2 signaling, they begin with the ligand binding at the surface, and it triggers then multiple downstream pathways. So the ligand binding to HER2 ARBB family, so it leads to heterodimerization, leading to receptor tyrokinase phosphorylation intracellularly. And there is the stimulation of the RAS-RAF-MEK pathway, leading to stimulation of multiple downgrade pathways, leading to gene transcription, tumor cell survival, proliferation, and metastasis. So there are various pathways, PIK3, AKT pathway, and RAS pathway that is further downregulated. So when we talk about the history of HER2 positive breast cancer therapies and testing, so it was actually discovered, the HER2 gene was discovered in 1984. And in 1985, HER2 gene amplification was described in the breast cancer, followed by the development of the targeted therapy and the approval for both early and metastatic settings. So in 2000, the first anti-HER2 monoclonal antibody was approved for the treatment of HER2 positive metastatic breast cancer. And in 2008, after 8 years, there was first tyrosine kinase inhibitor that was approved by the AMA for HER2 positive. And then alongside the testing guidelines, they also developed. So there is an ASCO-CAP guidelines that was renewed every few years to actually comprehensively explain how to actually describe HER2 positive, because it is very individual dependent. So HER2 testing, it plays a key role in patient management. And since the first guideline that was published in 2007, there are multiple updates that are available. So what is actually, what is the evolution of, testing of HER2? So when we talk about in 2000, when it was actually established, so HER2 positive was defined as IHC3+. That is more than 10% of the cells have HER2 positivity, they stain for HER2 positivity, or they were ISH positive. When we go to the 2007, there were first ASCO-CAP guidelines that were published. They addressed that there was high false positive rate, because since it was individual dependent, so there were, even if it is less than 10%, it was reportedly higher side. So they described IHC3+ as a uniform intense membrane staining of more than 30% of the invasive tumor cells. Then after a few years in 2013, these guidelines were updated again, since they were concerned about the false negative also, and they introduced the new ISH group. So they defined as a complete intense circumferential membrane staining in more than 10% of the invasive tumors, which was later clarified by the ISH equivocal report that we know, that is HER2 2+, that are further. And in 2019, and they were published the updated guidelines. So as we see, there are significant advances in the clinical practice and the standardization of HER2 testing. So because of the standardization of the reporting, there is a now reduced discordance rate of HER2 status. But still we see in our practice, the patients who are HER2 negative, and in the FISH it comes out to be positive, or they are positive here and the FISH came out to be negative. So comprehensive analysis of 5 neoadjuvant breast cancer studies, they comparing central and local HER2 IHC status, they show that there is the discordant rate as we can see, it was 52.4%, and then it was reduced to 8.4%. So over the 12 years, they have seen that it has markedly improved that HER2 expression with the evolution of the test standardization process. But despite the range of HER2 expression, clinical interpretation is binary, and it is based on validated IHC and ISH assays. So it is clinically classified as either positive. So what we call positive, either IHC 3+ or patient who are IHC 2+ but FISH positive. And the rest of the subset, they are categorized as negative. That is IHC 2+ who are FISH negative, IHC 1+ and 0. So as we see, IHC 0 and 1, they are HER2 negative. Equivocal, we do FISH. If it is FISH negative, it comes out to be negative. If it's positive or IHC 3+, they are considered as HER2 positive. But now there is a new perspective on the current classification of HER2 expression. Now even we are retrospectively analyzing the patient, because we used to write in our summary just HER2 positive and negative. And now we have to actually mention either the therapy is not widely available, but still for the data sake, we should know that how much patients they are actually HER2 low. So now between HER2 negative and HER2 positive, there is a new subset, that is the low levels of HER2. And 60% of HER2 negative patients are actually HER2 low. So what actually come into under HER2 low, that is the IHC 1+ and IHC 2+ with FISH negative. So when we talk about the further classification in this HER2 low expression, so tumor with low levels of HER2, they are more frequently hormone receptor positive and luminal type than HER2 negative breast cancer, that is the TNBC type. So the median age, when we talk about, when we talk about the median age, so it is comparable between the IHC HER2 negative and HER2 low. But when we talk about the HR positive, so when we talk in the low HER2 subgroup, it is 88.2% they are HR positive. The remaining 11% they are triple negative, as compared to HER2 negative, 30% are triple negative, whereas 70% of them are HER2 positive. So HER2 low, they were more frequently found within the HR positive disease compared to TNBCs. So IHC 0 and low HER2 expressing, they have different clinical feature because of the difference in the further subtype. So a study, it was aimed to provide a better understanding on the biological heterogeneity of this HER2 low. So they collected retrospective data from clinically HER2 negative data set, and they compared the clinico-pathological features between HER2 low and HER2 negative. And they have shown that the low levels of HER2, they are more frequently HR positive and luminal type, and they have a larger primary tumor and more nodal involvement than HER2 negative. So low level of HER2 expression may be found less often in the breast cancer who have a high histological grade. So as we say that the TNBC who have a high grade, so there are chances that they have a low HER2 expression. It is seen more commonly in the patients who have a higher nodal burden and HR positive tumors. So low HER2 expressing breast cancer, they are the heterogeneous group. So it is an important cause of equivocal HER2 IHC results. So tumor displaying heterogeneity, they are associated with larger size, higher histological grade, and the frequency of lymph node metastasis is higher in this low HER2 expressing subgroup. And despite increased heterogeneity, there is no significant prognostic difference have been found between low HER2 expressing and the HER2 IHC 0 subgroup. So how can we optimize the performance in the diagnostic process? It can improve the interpretation consistency across the spectrum of HER2 expression. So there are various factors who influence the actual staining of the HER2. What is the biopsy type? How do we handle the specimen? What are the type of assay that we are using, and what is the cold ischemic time that we are using? So all these factors, they influence the time. So there is a difference in the staining pattern also and the intensity also between the IHC 0 and the 1+. Though it is there is a subtle difference between the two, but still the difference is there. So a right microscopic lens is also critical to accurately assess the HER2 IHC score, as membrane staining is often not distinguishable at low magnification. So when we talk about HER2 IHC 3+, it is readily recognizable at even 5x or 2.5x power also. When we talk about 2+, it is visible at 10x, but not at 5x. And when we talk about 1+, it is not observable at 10x, and it is better visualized at 40x. So this is a interesting finding that as the expression increases, we need a higher power to actually differentiate between the 3+, 2+, and 1+. And this standardization is needed to improve the reproducibility between all the three. So what are the therapies? So there are various trials that were done for HER2 low breast cancer. So many HER2 related therapy have been studied to target the HER2 low expressing tumors. So previously, a lot of peptide vaccines and the antibody drug conjugates have been, studied with the monoclonal antibodies, even the immune checkpoint they have. And the first HER2 targeted therapy to actually show a benefit in HER2 low subset is the trastuzumab deruxtecan, and which has shown a clinically meaningful improvement in the PFS and OS versus the physician choice of drug. So even there are now trials that are, evaluating the AKT inhibitor, that is capivasertib, in this, along with the hormonal agents. So when we talk about trastuzumab deruxtecan, so it has a bystander effect, and so it has a 8:1 drug to antibody ratio. When we talk about the TDM1, the drug antibody ratio is relatively higher in the deruxtecan arm. There is a cleavable linker, and there is a highly potent topoisomerase 1 inhibitor payload that is seen in the deruxtecan. So when we talk about its mechanism of action, it binds to the HER2 receptor that leads to internalization of the molecule. So the linker is cleaved, which leads to the release of the topoisomerase 1 inhibitor. This topoisomerase 1 inhibitor then enters the nucleus of the cell, leading to the membrane permeable payload. So it results in even the bystander effect. So even the surrounding cells, they have effect because of the high drug payload, and there is a neighboring tumor cells infiltration also. So the results from phase 1b study, they have reported efficacy of deruxtecan in heavily pretreated patients also. So up to 6 lines of therapy patients have received in this trial with HER2 low metastatic breast cancer, with a median progression-free survival of 11.1 months and an overall response rate of 37%. So now there is a multidisciplinary, as we know in our clinical practice also, that a single doctor, they can't practice. Also, we need a multidisciplinary, and with a pathologist, the role is very important, which enhances the completeness, accuracy, and ease of reporting, producing a report. Clinician to increases the speed and accuracy of data extraction from those reports. Researchers and registrars ensure the data elements, they are amenable to a scalable data capture, interoperability and exchange, and the patient to contribute to the improved clinical care. So we need an optimal processes for assessment of HER2 status that is driven by an active engagement with a wider multidisciplinary team. So results, they allow clinician to discuss the prognosis and clinical management. So if there is a uniformity in the reporting of HER2 status, so it will be better for the future trials also, and can be subdivided into, for the IHC 2+, IHC 1+, what is the difference between the efficacy between the two arms. So as we see the latest NCCN breast cancer guidelines, so they have mentioned also that the distinction between HER2 IHC 0 and 1+ is currently clinically relevant in the metastatic setting, since the patients who have 1+ and 2+ with ISH negative results on primary or metastatic sample, they may be eligible for treatment targeting for the non-amplified level of HER2 expressions. So there are various retrospective study also to estimate the prevalence and describe the clinical-pathological characteristic and the treatment patterns of HER2-low cancer. So they have taken patients who were diagnosed with unresectable or metastatic breast cancer from 2014 through 17, and they have divided HR to HER2 negative as IHC 0, 1 plus, 2 plus, and any hormone status. And index date was the date of the metastatic diagnosis and up to the cutoff of 2020. So it is a global multicentric retrospective study, and the staff at the local laboratory, they blinded to historical HER2 score, that is rescored HER2 IHC stain style after training on low end. So the breast cancer were categorized as HER2 low, as we discussed, IHC 1 plus or 2 plus is negative, or 0, that is HER2 negative. And they have seen the prevalence of HER2 low in the real world data. What is the demographic, clinical pathological characteristic, treatment pattern, and the outcome in HER2 low versus the HER2 negative subgroup. As you can see, HER2 low was found more often in patients who were hormone receptor positive than the hormone receptor negative subgroup, and the HER2 prevalence by Ventana 4B5 was similar to the overall prevalence. So there are various clinical trials that are registered for deruxtecan in the HER2 low setting. So there is a Destiny Breast 06 trial, which is a phase 3 trial, also known as the HER2 ultra low, that is 0 to 1. So in this, they have taken hormone receptor positive HER2 low or HER2 negative advanced or metastatic breast cancer who have not received any prior chemotherapy for this setting, or they have progression on at least 2 previous line of endocrine therapy plus minus targeted therapy, or disease progression within 24 months, that is 2 years of starting the adjuvant therapy, or and on at least 1 previous line of adjuvant endocrine therapy in the metastatic setting. So the treatment arms were trastuzumab deruxtecan versus the physician choice of drug. So they have taken around 850 patients, and in the physician choice, they have taken capecitabine, paclitaxel, or nab-paclitaxel. So thank you so much.
Thank you, ma'am. Any questions? I'm sure madam will be happy to answer. Okay, I think it's still going to be absorbed and then gradually will come out later with you to the question, ma'am. Thank you so much, ma'am, for a nice and informative talk.
Thank you.
With this, I will now request Dr. Sandeep Kakkar. You all know him very well. He works in Sohana Hospital, and he's going to tell us something about CDK4 inhibitors, which have become a very integral part of most breast oncologists, and is trying to expand beyond that field also. So may I request Dr. Sandeep to kindly illuminate us about new knowledge or revise our old knowledges about the CDK4s and the 3 babies it has. Welcome, Dr. Sandeep.
Thank you, sir. Am I audible, first of all?
Yes, sir.
Yes,
Perfect.
yeah.
So, thank you, Dr. Jatin, for inviting me here on this platform and discuss something about CDK4/6 inhibitors. So, we all know. Are you able to see my PPT?
It's loading, sir. Yes.
So, it is showing that screen share is paused. Let me just share it again. Is it visible now?
Yes, it
Uh,
is visible, sir. Go
yes,
ahead,
sir.
please.
And
Sir,
that
please make it full screen. Yes, perfect, sir.
the slides are moving. Can somebody confirm?
Yes, sir, confirm.
Right, sir. So all set to go. At the end of the talk, at least we'll have something new to take out of it. What do we use nowadays in our clinical practice, and what is the standard of care, and what is the world moving forward towards in terms of CDK4/6 inhibitors and their alignment towards the subsequent therapies as well. So we all know that for hormone receptor positive and HER2 negative MBCs, CDK4/6, along with the endocrine therapies, is now the standard of care for ER positive patients, as it achieves a substantial progression-free survival. One or two agents, they do increase the overall survival and they maintain the quality of life. For some of the patients, those who have comorbidities or a poor performance scale, one might consider only endocrine therapies even in the first line, and they might preclude the use of CDK4/6 inhibitors. So we all know that CDK4/6 inhibitors, there is an interaction between the cyclin D and CDK4/6 that ultimately leads to the proliferation of the cell cycle and ultimately increases the number of cells. So this, once you stop this interaction between CDK4/6, the further activation of the cell cycles is suppressed and it leads to the degrowth of the cells. So we have three different agents that are approved in different schedules, different menopausal status of the patient, like first line, second line, premenopausal and postmenopausal. So palbociclib along with AIs has been approved in the postmenopausal females, ribo in the pre and the post, abema, in fact, even in patients who have received endocrine therapies and chemotherapies, it is approved as monotherapy. So this is an overview of the phase 3 trials with CDK4/6. That is, as we have evolved, the first was Paloma 2, that is palbociclib with AI, Mona Lisa 2, that is ribociclib with AI. Then came the data with abemaciclib, which led to the approval in terms of Monarch 3, followed by the use of these agents in the premenopausal females along with the ovarian suppression. Then there was the use in the endocrine resistant subset and the patients who had received prior chemotherapy for MBCs. So this is a basic overview where 2 points I would like to highlight here. That is, the agents like ribociclib and abemaciclib, they have proven time and again, they lead to an improvement in PFS and OS. But in terms of palbociclib, we all know that Paloma 2 and Paloma 3, in terms of PFS, great. In terms of overall survival, they did not lead to an improvement in overall survival. So three agents are approved depending on the three large phase 3 data that we have nowadays. But the primary endpoint was PFS in all the three studies. So this was Paloma 2 design, where you can see here palbociclib along with letrozole, which is again the standard of care. It led to the doubling of the progression-free survival with a hazard ratio of 0.58. But it did not lead to an improvement in the overall survival. There is almost overlapping of the Kaplan-Meier curves, whether you use endocrine therapy alone versus endocrine therapy with CDK4/6 inhibitors. In contrast to that, you have the Mona Lisa 2 data where ribociclib along with letrozole not only improved the progression-free survival and an impressive hazard ratio, but it also led to an improvement in the overall survival to the tune of approximately 1 year with a hazard ratio of 0.76. Thirdly, as we go on, the number of years go on increasing, like 4 years, 5 years, 6 years down the line, the magnitude of benefit with ribociclib, it goes on increasing. The delta of benefit, that is, you can see at the end of 4 years, it was 5.7, and at the end of 6 years, it is approximately doubling of that magnitude, that is 12.2. And all the key subgroups, whether it is the liver or the lung involvement, which was the majority stratification criteria of this trial, all these subgroup analysis clearly revealed that ribociclib and endocrine therapy is the way to go, and it also provides the overall survival benefit. Then came the Monarch 3 data, which again, in consistency with the other two, reflected and reciprocated the same findings of progression-free survival, almost doubling of the progression-free survival, and also an improvement in the overall survival with a similar hazard ratio of 0.75. The difference was again very, very similar, approximately 1 year, 12.6 months. So why there was no survival benefit with palbociclib? First of all, the trial was not powered to look for the overall survival, which was not the endpoint. Secondly, if you look at the trial design and the subsequent analysis, there was very high rate of crossover after this study. There are some key points again to look at, that although palbociclib has not led to an improvement in overall survival benefit, but the PFS data, if you look at the hazards, I'll be showing at the end of my presentation, the hazard was very similar, 0.56 or 0.58. But the real world data, it is somewhat different. We have seen time and again from the real world studies from India and across the globe, it also provides an overall survival benefit. The combined analysis of Paloma 1 and Paloma 2, it showed an overall survival benefit of approximately a year. But again, it should be taken with a pinch of salt that the phase 3 data did not show an overall survival benefit. Whatever may be the reason, the primary reason what the paper has said was the high crossover rates post this trial. So what about the premenopausal females? That is Mona Lisa 7, ribociclib, ovarian suppression, and tamoxifen. It led to an improvement in progression-free survival. It's very, very similar to postmenopausal females. Overall survival, again, very, very consistent, approximately 10 months of benefit with the addition of ribociclib compared to endocrine therapy alone. Whether you use NSAI or tamoxifen, there was an improvement in overall survival. So first line, we are very clear. You tend to use CDK4/6 inhibitor and AI as the standard of care. This is the message till now. So what about the second line? So second line, again, it becomes the data we have seen time and again. First, these agents were tested in the second line, then came the first line. So Paloma 3 with fulvestrant, it again showed that there is almost the doubling of the progression-free survival if you have used only fulvestrant. OS data was still not that impressive. Mona Lisa 3 clearly told that ribociclib along with fulvestrant is again leading to an improvement in PFS as well as OS. So second line also, what we do is we tend to use fulvestrant, or you can use fulvestrant along with ribociclib if it has not been used earlier. So Monarch 2, again, very similar and consistent findings as with ribociclib. That is, abemaciclib with fulvestrant not only improves the PFS, but also improves the OS. Safety summary, we all are aware about what kind of side effects these drugs are carrying. Myelosuppression, majority of the times with palbociclib, anemia, neutropenia, and thrombocytopenia. Ribociclib, hepatobiliary toxicities and myelosuppression, and abemaciclibs, again, myelosuppression and diarrhea, most common. But majority of the times, I think these are the kind of therapies which the patients can tolerate, and with a bit of, say, dose modification, for few of the patients, 10 to 15% patients would require some sort of dose modification with your drugs, and they can continue it till the benefit. So now we come on to this. Up till now, I think the data is more or less very, very clear that what we tend to do is, first line, we are very sure that AI and CDK4/6 inhibitor is now the standard of care. But is it so? Is it really that we want to use these drugs in the first line, or we tend to spare these drugs for the second line? So I will show an important and very interesting data regarding the optimal positioning of CDK4/6 inhibitors. And this data was first presented in ASCO last year, 2023, where the primary endpoint, primary goal of this trial was to compare the safety, efficacy, cost effectiveness of use of CDK4/6 inhibitors in the first line or the second line. So this trial was called as the SONIA trial. And we all know that the standard of care nowadays is CDK4/6. But what about using this drugs in the second line? Do we have a clear-cut answer to it that you can use these drugs in the second line? So I will show the primary endpoint of this trial was PFS2, that at the end of two therapies, CDK4/6 first line and fulvestrant in the second line, you tend to analyze the PFS2. What is there some difference between the PFS2 when you sequence the CDK4/6 inhibitors like that? Let us see. So if you look at the first picture, that is PFS1, the data is very, very consistent that we have seen hazard ratio of 0.59, first line CDK4/6, first line CDK4/6 with aromatase inhibitors, very, very similar looking Kaplan-Meier curves. So we are more sure that we are going in the right direction. Now you look at the PFS2 analysis, where you have used CDK4/6 inhibitors in the second line. The data clearly shows whether you use it in first line or second line, the outcome is going to be the same. You are going to achieve the similar kind of PFS and the similar kind of overall survival in the same setting, whether you have used the drug in the first line and second line. So what is the use of using the drug in the first line and second line? The trial not only painted a very different picture of CDK4/6 inhibitors, the conclusions mentioned that patients who had received in the first line, the researchers intended to give that CDK4/6 inhibitors for a duration of more than 16.8 months if you have given in the second line. So if you are using the drug in the first line, probably it adds to your cost, it adds to your toxicity as well, and you are gonna achieve the similar kind of survival. So the question still remains whether there will be a subgroup of patients where you want to spare your drugs for the second line. Another different approach for using CDK4/6 inhibitors was that the trial also mentioned that now we know that the overall survival data with ribociclib and with abemaciclib is there, but 90% of the patients in this trial, they use palbociclib, which is not the optimal CDK4/6 inhibitor nowadays. And secondly, you have diverse treatment options for CDK4, diverse treatment options in the second line. So here the second line was only fulvestrant, but you know that there are certain different agents like elastrant, like the use of fulvestrant and alpelisib, which are now the standard of care for the second line. So in terms of that, you can contradict the trial that the second line was not that optimal choice. Maybe the different sequencing is used. The trial was actually designed in 2007 and the analysis came in 2023. But still very interesting presentation in last year ASCO, where whether you use it in first line or CDK4/6 inhibitor in the second line, the outcome or the overall survival is going to be the same. I'll highlight another. So these are the conclusions. That is, optimal second line therapy was different. CDK4/6 inhibitors definitely matter because 90% of the patients here received palbociclib. The duration, yes, more toxicity and more cost addition was there when you have given in the first line. So who are the good risk patient where you can delay for CDK4/6? Although in our real world practice, everybody will be inclined to give CDK4/6 inhibitors in the first line. Secondly, is there a difference between the different CDK4/6 inhibitors? Now I will tell you about an interesting trial that this is again a phase 3 randomized multicentric trial, which is actually based on harnessing the tumor biology and targeting the specific cohorts. We all know about understanding from the gene expression profiling that RNA-based intrinsic tumor types are different. That is luminal A, luminal B, HER2 enriched, and the basal types. So you have 4 different types, and how the data has evolved in the Mona Lisa trial, that more from the data from Mona Lisa 2, 3, and 7, they showed that for those categories like HER2 enriched, where you have the addition of ribociclib, the intrinsic subtypes could be reverted. So it is not that the subtypes that are there from day one, they cannot be reverted. So usually what happens over a period of time, the subtypes, they move from less aggressive ones to the more aggressive ones. But if you administer ribociclib to some of the patients, the tumor types can have a switch from the endocrine resistant ones to the endocrine sensitive ones. So this was the basis of this trial, where I think the data would mature and it would come, but how the science is evolving, that I wanted to highlight. Even in patients, those who are hormone receptor positive, people are trying to delineate whether there are certain subgroups where after a certain period of time, the subgroups can again be reverted back into the endocrine sensitive ones, and you can re-challenge them with ribociclib and endocrine therapies. So this was the primary cohort, and the secondary exploratory cohort was the basal-like, where the only paclitaxel was given, and now they have started using paclitaxel with another anti-PD-1 monoclonal antibody, that is tislelizumab. So I think this trial, the data would be coming later half of this year, where we will come to know whether harnessing the similar amount of benefit with when you are targeting the tumor biology and the endocrine resistant clones, is it a favorable approach or not? So it is, yes, beyond the CDK4/6 inhibitors. Now, another interesting point is that usually what we face in our day-to-day clinical practice when the patient has progressed on CDK4/6 inhibitor, whether we want to continue CDK4/6 inhibitor or whether we want to switch over to only endocrine therapies. So we have a conflict of opinion or contradictory opinion from the phase 2 data that is available. So first, I would like to present the maintain trial, where I would not go into the much detail of this trial. And this data was again presented, and we know from the preclinical and clinical studies that targeting endocrine therapy is usually favored, because we believe that over a period of time, it is the endocrine receptor that is working. The changes in the CDK4/6 inhibitors are not that rampant. So one tends to change the endocrine backbone rather than continuing the palbociclib. So the data from maintain trial, it was very much positive, and it concluded that the patients who had progressed on AI and palbociclib, you change the backbone, that is fulvestrant with ribociclib, there was an improvement in the progression-free survival. But on the similar lines, if you see the data from the PACE and the Palmyra study, and this data was presented 2 years ago in the San Antonio Breast Cancer Symposium, where fulvestrant along with continuation of CDK4/6 inhibitors was seen, the PFS was almost very similar. So you don't have a clear-cut answer to it, whether continuing palbociclib with fulvestrant is the right approach or changing the CDK4/6 inhibitor is the right approach. So we had 3 different messages from the trial. One was the SONIA trial, whether first line or second line. Second was harnessing the tumor biology in HER2-enriched types in HR-positive tumors. Third is continuation of CDK4/6 inhibitors beyond the disease progression. So these are the key takeaways from my trial, and this is what I wanted to highlight. So this is the trial that we have till now, pre-menopausal and post-menopausal. You can see the hazards at the bottom of the table. That is almost very similar, and for the pre-menopausal as well as the post-menopausal females. So thank you, and thank you, Dr. Jatin, for providing the opportunity. If there are any questions, I'll be happy to answer.
Dr. Sandeep, can I ask you one question?
Yes, sir, please.
Out of the 3 aromatase inhibitors, your recommendation would be to use ribociclib or abemaciclib. Is it, if I'm correct, in adjuvant setting? Sorry, in adjuvant setting.
So
and in metastatic settings also, in both settings, adjuvant and metastatic, which one would you recommend?
Right. So for the metastatic setting, the data clearly says it is in favor of ribociclib and abemaciclib both. You can use any of the agents depending on the trial data that we have. And we use both the agents depending on the comorbidities of the patients. You can use any of them. As far as the adjuvant setting is concerned, I think NATALEE data has been there, but I have not gone into the details because the paper is still not out. I am using abemaciclib for the adjuvant settings, and we all know that for high-risk subgroup of patients, adjuvant abemaciclib is the way to go. I think as the data from NATALEE trial would evolve, one more agent would be there in your armamentarium for use of your own patients. For metastatic, it is clear that if you look at the PFS and OS data, it is very similar. You can use any of the agents.
Thank you, Dr. Sandeep. Any more questions from the participants, please? If nothing, then thank you, Dr. Sandeep, for a very informative talk on a pretty complex topic. I now hand over back to the organizing secretary and chairman, Dr. Jatinder, to take over the talk forward, the conference forward. Thank you.
I thank both the previous speakers. They have done justice to whatever was given to them. We had a very informative session on HER2 testing and how to define HER2 low very clearly. And also we could hear some interesting perspectives on usage of CDK4/6 inhibitor in the metastatic setting. And the question which Sandeep raised about the first line versus second line usage is a very, very relevant question. And it was very relevant when we didn't have generics, and that dilemma was always faced and was discussed in various forums. And Sonia trial is a very, very interesting trial. Thank you for bringing this out. And now I think I would like to invite Dr. Devinder Paul for the next session, who is going to speak on now HER2. We'll switch gears. We'll be focusing on HER2 uh, uh, breast cancer, and he'll be speaking on evolving trends in management of HER2 positive metastatic breast cancer. And Dr. Devinder Paul, everybody knows him pretty well. He's a senior consultant at Fortis Hospital, Ludhiana. So over to you, Devinder.
Good evening.
Mm.
Can somebody upload my slides, please? So good evening, everybody. Thank you, Dr. Jatin, sir, for inviting me for this talk. I'll be talking about the evolving trends in the management of HER2 positive metastatic breast cancer. Next slide. So this is the outline introduction, unmet needs for the second line, recent advances for the HER2 positive metastatic breast cancer regarding the role of new drugs like the HER2, neratinib, tucatinib, current treatment algorithm for the HER2 positive metastatic breast cancer, and some take-home messages. Next slide. Next slide. So we all know about the breast cancer. It's one of the most commonly cancer which we deal in our clinical practice. It is one of the most common cancer worldwide. And approximately 30% of all breast cancer cases will become metastatic after diagnosis. And HER2 positive breast cancer are associated with aggressive behavior, we all know. And 15-20% of all invasive breast cancer cases are HER2 positive. You can see if you see HER2 low and HER2 HR negative and HER2 positive, they are around 8%. HER2 and triple positive, they are around 13%, total combined 20.7%. But the primary patient pool remains the HR positive, HER2 negative, and the triple negative, they constitute around 15%. In our setting, it is slightly different. Triple negative is slightly on the higher side, and her endocrine HR positive HER2, they remains around 60 to 70%. Next slide. So a few different discoveries in the HER2 landscape have really shaken the foundation for the cancer treatment, like the discovery of human epidermal growth factor, that is the HR2 oncogene. We all know it's the oncogene, and the HER2 overexpression confers an aggressive tumor behavior, but also gives us all an opportunity for the targeted therapy. Next slide. So regarding the unmet need for this these patients, next slide. So as the HER2 target options, they continue to expand. We all physicians and oncologists, we weigh many factors while sequencing the treatment. More than 1/3 of patients will not receive subsequent therapy after the second line of treatment, and many will miss an opportunity to receive a highly effective HER2 targeted agent if it is not prioritized at an early stage. You can see in the first line setting of such patient, once they progress, almost 78% of patients will receive the second line, around 22% will drop out. And after the second line, almost 65% will receive the third line, and about 35% patient will again drop out. And so you can see, so the sequencing decision, that primarily depends upon the or previously administered therapies, progression-free intervals, sites of progression, tumor burden, patient preference, and quality of life. In our setting, of course, the finances also. Next slide. So the key data supporting the existing therapies, first line Cleopatra trial, which documented the role of docetaxel plus trastuzumab plus pertuzumab. You can see it attained a median progression-free survival of around 6.3 months higher as compared to the comparator arm. and the OS benefit of almost 16.3 months as compared to the comparator arm. And in the second line, you can see Amelia trial, in which the TDM was compared with lapatinib and capecitabine. Again, they showed a PFS benefit of around 3.2 months and a OS benefit of 5.8 months, although the toxicity was higher in the comparator arm in the Amelia trial, and TDM1 was quite easily it was seen to have lesser side effects. Next slide. As I told you, the median PFS drops by approximately half, moving from first-line treatment from the docetaxel plus Phesgo to second-line treatment with TDM1. You can see in the Cleopatra trial, the median PFS was around 19 months, but in the second-line Amelia trial, the median PFS was just around 9.6 months. And these trials were, they both came in the same year, that's 2012. And thereafter, we have some real-world evidence studies on the second-line TDM1 following the use of pertuzumab. So we have seen that if you use a second-line TDM1, the outcomes of those patients who have already received pertuzumab in the first line, the TDM1 was not showing that much benefit as compared to those patients in whom the pertuzumab was not used in the first line. So the available data are limited to the real-world evidence, and they have shown reduced efficacy with the TDM1 following the use of pertuzumab in the first-line setting. Next slide. So the evidence suggests that the PFS outcomes for the second-line TDM1 are worse in patients who received the prior pertuzumab. You can see there are two large real-world Italian studies which have evaluated this scenario, and they have shown that if the patients have already been exposed to pertuzumab in the first line, there was significantly worse PFS when we use the TDM1. Next slide. So there must be a rationale for this. So the rationale which has been given is that once the patient has been subjugated to upfront dual anti-HER2, there is a reduced outcome with the TDM1 because there may be reduced HER2 expression. You can see on the left side the patient specimen after the exposure from just docetaxel and trastuzumab as compared to the use of dual anti-HER2 molecules. You can see after the use of dual anti-HER2 molecule, the HER2 expression decreases, and that and in the TDM1, the molecule has limited permeability in this setting because it has to go and combine with the HER2 molecule on the surface of the cell. So if there is a reduced HER2 expression, the efficacy of this molecule decreases, and this further supports the impact of HER2 expression on the TDM1 effectiveness. And the data is there for the post-hoc analysis from the Mariana study, and especially in the patient who had a heterogeneous, that is 30 to 80 plus 79% HER2 expression, that is 2 plus 3 plus, they fare far worse as compared to patient who had a homogeneous HER2 expression, that is more than 80%. And they achieved a shorter median PFS with the first-line TDM1, that is 8.3 months compared to 14.7 months in those who have a homogeneous expression. Next slide. So recent advances in this scenario. Next slide. So there has been an unprecedented flourishing of anti-HER2 molecules in the last few years. 8 anti-HER2 drugs have currently authorized by the US FDA for the metastatic breast cancer. Half of those approved in the time frame of the last 1 year. We know in the 2019 came the trastuzumab deruxtecan, followed by neratinib, tucatinib, and now we have also mirvetuximab, which is also there. Next slide. Regarding the male molecule which we are discussing today, the trastuzumab deruxtecan, that is the HER2. Next slide. So we all know the mechanism of this drug. It is an antibody drug conjugate. So you can see on the left side, it combines two things. We have a highly potent topoisomerase 1 inhibitor payload, and we have the linker which links it to the trastuzumab. So what happens is once it combines with the HER2 receptor on the surface, it is internalized, and after it goes through the cleavage, the topoisomerase 1 payload is unloaded. It goes into the nucleus and it destroys the cells. And the more important thing is that it has a bystander effect, because some of the molecules and molecules, they have permeability. They go across the cells and they have a bystander effect in the surrounding cells. So this molecule has demonstrated response to the therapy in around 61% pre-treated patient population with HER2 positive breast cancer in the third line. Sorry. Next slide. So ADC characteristic, there are difference between the HER2 and the TDM1. You can see the payload in the HER2 is topoisomerase 1 inhibitor. In the TDM1, it is the anti-microtubule. Drug to antibody ratio is far higher in the HER2, that is 8:1 as compared to 3.5:1. There is no tumor selective cleavable linker and in the TDM1, which is there in the HER2, and there is the evidence of bystander anti-tumor effect is not seen in the TDM1, but it's quite seen in the HER2. Next slide. So the pivotal trial regarding the HER2, the trastuzumab in the third line setting, the Destiny Breast 01 trial, open label multi-center phase 2 study. You can see on the left side the inclusion criteria. They also took into the account the pre-treated and stable brain metastasis patient. Also, they randomized to either TDM1 or to an HER2. And you can see in the part 1 study, the PK analysis was done, and it's part 2 and followed by dose fixing finding were done. And finally, in the third arm, there is a continuation arm, and the patient were continued on the HER2 arm. 184 patients were enrolled at a 5.4 milligram per kg dose, which we all use now. Next slide. So the primary endpoint was the overall response rate, and secondary endpoint was the overall response rate, disease control rate, duration of response, and the PFS, OS, PK, and the safety analysis. The median duration of follow-up was till August 1, 2019, data cutoff of 11.1 month, followed by June 8, 2020, data cutoff of around 20.5 months. Next slide. Demographics, you can see both the patients who are hormone receptor positive as well as negative, they were taken into account. You can see almost 52.7% patients have a hormone receptor positivity, and you can see in the other arm, the HER2 3+ was almost 83%, HER2 2+ with ISC positive, and FISH positive was seen in around 15% of the patient. Next slide. Next slide. Yeah. So you can see the patient who had previous systemic therapies, almost all of them had received either pertuzumab, or all of them have either received trastuzumab or TDM1, and pertuzumab also seen in the previous therapy. And best response to TDM1 therapy was evaluated in the form of CR, PR, stable disease, and of course progression disease. Next slide. So you can see from this first waterfall curve that the best percentage change for baseline target lesion, median time to response was 1.6 months, and the confirmed overall response rate was 62%, and median duration of response was 18.2 months. Next slide. Subgroup analysis, and in the subgroup analysis, consistent overall response rate was observed in all the subgroups. You can see in all these things, almost all were favoring the HER2, whether it's the presence of, whether there is the presence of prior pertuzumab therapy, or the presence of visceral disease, or the presence of HER2 positivity. All they were primarily favoring the HER2 arm. Next slide. So median duration response is 18.2 months with this molecule. Next slide. And the median progression-free survival was 19.4 months. Next slide. And the median overall survival was 29.1 months with this molecule. You can see at the end of 12 months, 18 months, and 24 months, the overall survival was around 85%, 75%, 58%. Next slide. So regarding the CNS activity, you can see the median time to response was 2.8 months for the CNS subgroup and 1.6 months in the HER2 arm. You can see duration of response was 16.9 months in the CNS subgroup, and in all the patients that was around 14.8 months. So it has a good intracranial activity also. Next slide. So regarding the adverse events, basically it's a fairly safe drug to use. The primary toxicity which you can see is primarily the nausea, fatigue, alopecia, vomiting, some sort of constipation, and neutropenia was there, but it was not that to the tune which we see in the TDM1 now. Next slide. The AE of special interest which we have to take into consideration with HER2 is the ILD and the pneumonitis. So the most first cases of ILD events occurred during the first 12 months of treatment. The risk of adjusted drug-related ILD appears lower after approximately 12 months of treatment, suggesting that the risk of developing ILD is not related to the cumulative dose of HER2, and there should be continued attention to pulmonary symptoms and careful monitoring is warranted. You can see in the upper slide, as of the data cut of June 2020, only the primarily toxicity of ILD was seen in the form of grade 1 or grade 2 toxicity. Grade 3 was just in one patient. Grade 4 or 5 was not. Grade 5 was seen in around 5 patients. Next slide. So regarding this HER2 in the second line study, the Destiny Breast 03 trial, again an open label multi-center phase 3 study. You can see the patient criteria and the stratification factors. Again, the hormone receptor positive patient were taken into study, and the prior treatment with pertuzumab was also allowed. This was randomized to either an HER2 or to a TDM1 arm. And the primary endpoint was PFS, secondary was OS, overall response rate, duration of response, PFS, and the health-related outcomes. Next slide. The baseline characteristic and the prior therapies were well balanced in both the arms, you can see, and in many of the patients were taken from the Asian subcontinent only. Next slide. So more than 20% of patients had any recorded history of brain metastasis, and approximately 50% of patients had clinical stable brain mets that were observed at the baseline scan. You can see from this side that even the patient with baseline brain metastasis, they were taken into account. Next slide. So approximately 60% of patients in India received the prior pertuzumab. You can see any prior therapy, which we can see in both the arms, they take into account both the trastuzumab, pertuzumab, and they were equally balanced in both the arms. Next slide. So primary endpoint PFS by the blinded internal review, 72% reduction in the progression of death. You can see at the median progression-free survival with the Enhertu was not reached, and with the TDM1 was 6.8 months, and the median 12 months PFS rates was 75.8% with the Enhertu and just 34% with TDM1 with the HR ratio with the p-value of 0.08. And at the data cutoff, around 84, that is 32% patient treated with Enhertu versus 59% patient with TDM1 had a progressive disease. Next slide. Subgroup analysis, again, you can see all were favoring the Enhertu as compared to TDM1 arm, including the brain metastasis at the baseline and the history of brain mets in the previously or the prior lines of therapy. All were favoring the Enhertu arm. Next slide. So overall survival by the subgroup analysis, you can see again whether we take into account the hormone receptor status, prior pertuzumab, baseline visceral disease, prior therapies, lines of systemic therapy, or the baseline presentation brain mets, all were favoring the Enhertu as compared to the TDM1. Next slide. Some analysis were done for the PFS Kaplan-Meier curves. You can see in the brain mets at the baseline, there was a wider difference as compared to the patient who doesn't have a baseline metastasis. At the data cutoff in the patient with brain mets at baseline, progressive disease was observed in 21 out of 43 patients treated with Enhertu versus 27 out of 39 with the TDM1. In the brain, in around 9 by 21 treated with the Enhertu versus 11 out of 27 with the TDM1. And at the same data cutoff, in the patient who doesn't have a brain mets at the baseline, progressive disease was observed in 63 out of 218 patients with the Enhertu as compared to 128 out of 224. That is almost more than half with the TDM1 arm. Next slide. You can see from this curve, confirmed overall response rates and other efficacy endpoints. Confirmed overall response rate, you can see it was 78.5% in the Enhertu as compared to 35% in the TDM1 in the third line setting, with the CR rates of almost 21% in the Enhertu and with just 9.5 months with the TDM1 arm. And next slide. So you can see the PFS2 and the post-study anti-cancer treatment which we received. Any post-cancer, you can see in the Enhertu, the most of the patients they received later on, either they were just either continued with the Enhertu or they received TDM1, and in the patient who had a TDM1 arm, they primarily received the Enhertu in the subsequent therapies. Next slide. Safety summary, you can see any drug-related events, they were seen in around almost 98% with the Enhertu. But if you see grade more than equal to 3, that was seen in 47% with the Enhertu and 42% with the TDM1. And the serious events were seen in 12% in the Enhertu as compared to 7.7% with the TDM1 arm. And regarding drug-related adverse event which led to drug discontinuation, it was seen around 20% in the Enhertu and 6.5% in the TDM1 arm. The most common drug-related events associated with the discontinuation were in the Enhertu arm were the pneumonitis 5.8%, ILD 5.1%, and the pneumonia. And in the TDM1 arm, we all know primarily the platelet count thrombocytopenia, pneumonitis is seen 1.1%, and this was the primarily with the TDM1 arm. Next slide. So regarding the most common AEs in more than equal to 20% patients in the TDM1 arm, as I told you, primarily the blood-related toxicity, anemia, thrombocytopenia, white cell count, they were there, but they were primarily more seen in the TDM1 arm. The GI toxicity was also seen, and other features like fatigue and headache was also seen primarily with the Enhertu, and they were less seen with the TDM1 arm. And regarding the liver transaminitis, they were primarily seen with the TDM1 as compared to the Enhertu. Next slide. Adjusted drug-related ILD events or pneumonitis event, you can see in the TDM1 in the Enhertu arm, they were primarily grade 1, 2, or 3, but they were far less in the TDM1 arm. And so these rates were similar to other metastatic breast cancer trial with the Enhertu. With longer treatment exposure and follow-up, the ILD pneumonitis rates, they increased from 10.5% in the PFS interim analysis to 15.2%. and their overall incidence of grade 3 events was just 0.8%, and that was similar to the PFS interim analysis. And there was no adjusted drug-related grade 4 or 5 events seen in the ENHERTU. Next slide. So the ESMO 2020 update, time to definite deterioration in the PRO measures were numerically prolonged with the ENHERTU. You can see the time to deterioration after ENHERTU was far longer as compared to the TDM1 arm, and the overall health status and quality of life were far better maintained with the ENHERTU as compared to other therapies. Next slide. So conclusion of this Destiny Breast 03 trial, this is the first randomized phase 3 trial in the breast cancer which has demonstrated that ENHERTU has a clinical meaningful and statistically significant improvement in PFS compared to the TDM1 arm in patients with HER2 positive metastatic breast cancer with the PFS by the blinded review with HR of 0.08, and there was a consistent benefit was seen across all the key subgroups and the efficacy endpoint with a confirmed overall response rates of around 80% versus 35% of the TDM1 arm, and there is an encouraging OS trend at the time of first interim analysis, and there is a statistically significant difference at a later follow-up. And the 12-month OS rate for the ENHERTU was 94% versus 85% with the TDM1 arm, and the safety profile that was seen was comparable between the two arms. Next slide. So these data, of course, support the use of ENHERTU, and it has become the standard of care for the second-line HER2 positive metastatic breast cancer. Next slide. So now I'll be going across two drugs which also have been shown to have very good effect, tucatinib. Although these are not available in India right now, but of course we have used in few of the patients. Next slide. Tucatinib came into account after the HER2 study, randomized double-blind multi-center placebo-controlled phase 2 study. You can see the inclusion criteria. They also took into account the stable brain mets and the untreated brain mets and not requiring any immediate local therapy. You can see the randomization to either tucatinib plus trastuzumab plus capecitabine or placebo plus trastuzumab plus capecitabine. Next slide. So in this trial, it met all the primary and alpha controlled secondary endpoints at the first interim analysis. You can see the PFS showed that the risk of progression or death was reduced by 46%, overall survival, and the risk of death was reduced by 34%, and the PFS in the patient with brain mets, the risk of progression or death was reduced by almost 52%. Next slide. You can see the same thing in the different slide. The overall response rate of 41%, the median PFS benefit was to the tune of 3 months as compared to the comparator arm, and the OS benefit was to the tune of around 4 months as compared to the comparator arm. But the thing is that the adverse events of the thing which was quite worrisome with this molecule, diarrhea, the hand-foot syndrome, nausea, fatigue, vomiting, they were primarily the symptom side effect, and grade 3 or more adverse event occurs in 61% of these patients as compared to 51% with the trastuzumab and capecitabine arm. Next slide. So the efficacy in brain mets, this molecule has a very, very high penetration in the brain. You can see the median PFS with this triplet. You can see in the patient with brain mets, you can see 7.6 months as compared to 5.4 months with a p-value which was very, very significant. And the patient who doesn't have a brain mets, 9.6 months, 6 months as compared to 6.8 months. And the overall intracranial objective response rate from this trial, you can see 47% in the triplet arm as compared to just 20% in the placebo plus combination arm. Next slide. So this trial showed that it has statistically significant CNS penetration and PFS and OS benefit in the CNS, and both in the CNS as well as in the patient who doesn't have a CNS metastasis, but primarily in the CNS mets, this drug had a higher PFS as compared to the other molecule. Next slide. So diarrhea was, as I told you, diarrhea is the most common AE with the tucatinib triplet combination. 81% patients have this, and most of the people, they say that once we start tucatinib, we have to start at lower dose and we have to use prophylactic drugs to control the diarrhea. And you can see from this slide, the diarrhea was seen in 81% of the patient, grade 3 was 13%, and the other toxicity was hand-foot syndrome, which was seen in 13% with the grade 3 toxicity. And remaining toxicity were there, but they were not that great as compared to these two toxicities. Next slide. Regarding neratinib, next slide. Again, a molecule which has shown benefit in the metastatic setting and also has been shown to have some benefit in the adjuvant setting also, although it's quite questionable right now. So regarding the pivotal NALA trial, it showed it has a combination neratinib plus capecitabine versus cape-lepatinib in the patient who have previously received more than 2 lines of these molecules in the HER2 therapies. And you can see the randomization. You can see that they were randomized to 1:1 arm of either neratinib plus capecitabine with the low pyramidal prophylaxis and capecitabine and lepatinib. and the primary endpoint was the PFS and the OS. Next slide. Again, you can see that it showed a very significant benefit in the PFS favoring this neratinib arm, translating to a 2.2 months mean PFS improvement without any significant benefit in the OS. So OS benefit was not there, but the PFS benefit was there. And the median PFS was 8.8 months compared to 6.6 months. And the median overall survival was 24 months as compared to 22.2 months. Again, the AE, primarily AE remains the diarrhea and the hand-foot syndrome and the GA toxicity. And grade 3 or more than grade 3 AEs were seen 24% in the neratinib arm. Next slide. Safety data, as I told you, you can see diarrhea was managed with the mandatory prophylaxis in this cycle 1, and loperamide was needed thereafter. It was less severe than observed previously, as if we use the loperamide as compared to the other phase 1, phase 2 studies. But again, as I told you, this is the primarily toxicity which leads to drug discontinuation in almost 13% of the patient, regarding dose, leading dose reduction in almost 25% patient. And you can see the other side effects, they were there, but primarily toxicity was the diarrhea and the GI toxicity. Next slide. So regarding the current treatment algorithm for these patients, next slide. So the current treatment option for these patients remains the first line data supports the use of pertuzumab plus trastuzumab plus docetaxel category 1. And we have data, then we can also change docetaxel to paclitaxel. In the second line option, quite few years back, it was only TDM1 arm. But now, as I told you regarding the Destiny Breast 03 trial, we have option of using an HER2 in the second line. Of course, we can also use the TDM1 arm. In the third line, we have multiple treatment drug combinations which can be used. Tucatinib, we can use, if it's already not used, we can use an HER2, we can use cape-lepatinib, cape-trastuzumab plus lepatinib. Also, we can use neratinib, and other drugs also are available. Next slide. So these are the NCCN guidelines. You can see again the first line use is of the dual anti-HER2 plus the chemotherapy arm. Second line, we have firmly now placed the HER2. It is a category 1. And third line, we can use TDM1 arm, TDM1, and other remains the tucatinib plus the trastuzumab and capecitabine. In the fourth line, we can use all the other molecules which are available. Next slide. So the take-home messages. Next slide. So between first line and the second line, there is almost a PFS drops to almost half. And so we have to use a very big good drug in the second line. And the drug which has shown the best response and the best durable response remains the HER2. And so the docetaxel plus Fasco followed by HER2 after progression is now considered to be the standard of care after the initial therapy. And we have a multiple third line option, including neratinib, tucatinib, and HER2, and bergetuximab, which are now available. However, the optimal sequence in the third line setting is still not clear. And I'll say in our setting, it's not even clear in the second line because of the financial constraints and all other factors involved. Next slide. So these are the disclaimers. Next slide. So that will be all from my side. I'll be happy to take any questions if there are any.
Thank you, Devinder, for an extensive talk. And we'll be taking the questions in the panel discussion. And before that, just one or two questions. In today's era, after using THP, would you go and use TDM1 in second line?
Yes, sir. Of course, I'll use, if the patient has already received pertuzumab, I'll be more than happy to use an HER2 in the second line, because as I showed you the evidence.
No, I'm asking TDM1.
Yes, sir. TDM1. If you're saying yes, of course, sir. If the patient has already been first line has been progression, if there is an HER2 is not available, and then of course the best option remains the TD1.
Okay. And second thing, in the HER2 climb study, do you think the comparator arm was good enough?
No, sir, it was not good enough, actually, to be fair to you. It was not, it's not really a very, very randomized trial. It was a randomized trial, but it was not, the comparator arm was not that good. I'll say that.
Thank you. And we'll be having some more interesting questions. So now we go on to have again something about HER2 low breast cancer. And well, I was exposed to HER2 low entity as far back as 4 years, when in our group, my mentor, Dr. Pankaj Shah, posted an article of HER2 low, and that was the first time I was exposed to HER2 low. But now it has become the talk of the town. And Dr. Ashwin Phillips, who's a senior medical oncologist in Ludhiana, practicing as CMC in Mohan Oswal Cancer Center, he'll be taking us through to treatment or management of HER2 low breast cancers. Dr. Ashwin.
Thank you, sir. Thank you so much for this introduction and thanks for the opportunity. Like you said, it's becoming more and more molecular and more precise today. So, is my slide visible?
Yes, the slide is visible.
Yeah. So, I'm going to talk about HER2 low, which is an important entity. Before the start also, I would like to say it's not just HER2 low. Today, we're looking at a lot of other things. There's a lot of interest in I'm doing a research on a low ERPR expression as well. Not that everybody who has a 1% and 1 to 10% of ERPR is also an interesting area of oncology right now. So I'll be looking into my talk. I'll be talking about the HER2 receptor, what it means to us, and what it means about HER2 low, the biological landscape of the low expressions, the current guidelines and the unmet need, and a few trials and the future directions. Now, we all know that breast cancer is heterogeneous. We have the luminal A, B, the HER2 positive, and the triple negative. And we know that the best subset is the luminal A, which has a high hormonal receptor, low Ki67 or low proliferation. They do the best. A luminal B will be somebody who has a lower expression of the hormones and a higher proliferation. The triple negative, that itself now has many subtypes, under at least 5 subtypes under it on a molecular basis, and the HER2 positive or the HER2 enriched. No, there has been a lot of studies, and basically, Dennis Lehman did a lot of work initially to bring you the first monoclonal antibody against the HER2 expression, in which you had trastuzumab approved in 2000 as metastatic in metastatic breast cancer who had a HER2 positivity. And down the line, we developed guidelines as to how do we check for HER2 in these subset of patients. Then you have the tyrosine kinase inhibitors coming up. Then you have the antibody drug conjugates coming up, and now you're having more and more modifications on drugs and better drugs coming up in the entire process. Now, we all know that HER2 expression is continuous from a score of 0 to 1 plus 2 plus and 3 plus. You would consider a patient to have a HER2 positivity if the score is 3 plus. That's based on the membrane staining. So if you have more than complete staining and of intense membrane staining, at least more than 10% of the cells, they are considered as 3 plus. If you have a moderate to weak staining, around 10% of the cells, it is considered an IHC of 2 plus and it's equivocal, where you do a FISH to confirm it. Now, if you have incomplete and faintly perceptible staining, then you would call it a 1 plus, and it's completely absent, it's called 0. Now, the area of interest that we're looking at is this 1 plus, 2 plus, and those ones that are FISH negative. So the reason behind is that majority of your patients would be considered HER2 negative previously, because they would be HER2 FISH negative or 1 plus by expression. So we're trying to see how these patients behave, and the fact that there's been a lot of data showing that those patients who have a low HER2 expression would have a higher hormone positive expression and would have a lesser aggressive disease and a slow disease burden. So based on that, there's been some interesting thing that has gone behind. So the current paradigm would say that majority of your breast cancers would be hormone positive. A small subset would be HER2 negative, HER2 positive, and a very small subset would be triple negative. But in the future, this is going to change with, it's already changed. I wouldn't say the future, it is going to be like you have the hormone positive, then you have the low HER2 positive and hormone positive, and the low HER2 positive hormone negative, and the complete triple negative. Now, this has been a beautiful, all these things come from a lot of retrospective data. I'm a huge fan of collecting retrospective data because of the fact that I know people say that retrospective studies have their own set of biases, but the thing is that it helps you to understand how your patients have behaved over a period of time, especially in the real world setting. A lot of trials look at very clean, select patients, but a retrospective real world data gets you to see how these patients behave with treatment. So what we see in all these retrospective data is that majority of these patients who are low hormone HER2 expression were associated with hormone positivity, and irrespective of the type of platform that you use to check your HER2, they were comparable. So what you're going to see is that they are more closely linked to the hormone positive subset, the lower hormone HER2 expressions. Now, like I said before, this is what we see. They have a low K67 and they respond less to neoadjuvant chemotherapy. Now, this is a pool data which looked at patients who are in all the neoadjuvant trials, the Japaceto and the Japarex and all those trials. They looked at those patients and they found that, again, these patients who have a low HER2 expression behaved very different from those patients who have a HER2 zero expression with regard to the hormone receptor status, the proliferation, and the response to neoadjuvant therapy. So what they saw is that these patients who have a low HER2 expression had a better survival as compared to those patients who had a HER2 zero expression. Uh, so that was something that is important. That so having some expression had some benefit other than having no expression at all. So like I mentioned before, when they analyzed they found that these HER2 low positive patients had a less grade 3 tumors, low proliferation, and less TP53 mutation. So they did behave a lot more differently than what you would see with your triple negative. So they were not exactly triple negative. And this is what I also, the data that we're analyzing, that the low ERPR breast cancers are not just hormone positive, they behave more towards the triple negative. Similarly, what you see is that some sort of a HER2 expression is not putting it towards your triple negative. So they would behave differently than from the patients who are HER2 negative. And what they saw in this subset of patients is that those patients who were HER2 low and were hormone negative had high PIK3CA mutation. So all these things were picked up in a lot of landscape studies. So why is this an unmet need? Is that we all agree to the fact that hormone positive breast cancer, CDK4 inhibitors, either in the first line or the second line, is going to be the standard of therapy. At now, there will be better drugs coming in. But right now, either you use CDK4/6 inhibitors first line or you use second line, depending on the patient's condition. And you know that we all discuss about the best drugs, whether ribociclib is better than abemaciclib. All those discussions are going on. But once you progress on this hormonal therapy, then you develop endocrine resistance and you have an ESR1 mutation, all those things coming up. So your next line of therapy depends upon your PIK3 mutations present or not. If it's ESR1 positive, these patients, then you based on if you have especially if you're exposed to CDK4 inhibitors, you have limited options down the line in terms of endocrine therapy having a good response rate. In the triple negative, we have always struggled because of the fact that they're aggressive diseases. Single agent chemotherapy would be the standard of care. You would consider adding platinum at some point of time. Today, you're talking about immunotherapy in the subset of patients. But even with the best of treatment in the subset of the median survival is still around a year and a half, at most of the studies have shown. So this is the area which is an area of interest to identify a subset of cancers which are not exactly triple negative and which are not exactly hormone positive all the time. So in the hormone positive subset, you have the best response is always in the first line setting or your first line therapy, either your single agent hormonal therapy or your CDK4/6. It gives you a better PFS. Most of the studies did not show an OS survival except for the ribociclib and abemaciclib. So once you progress past endocrine therapy, you're left with a few options of chemotherapy, and there the outcomes, the PFSs are not that great. And the triple negative, we already know that it is even more difficult because the disease burden is high, the disease itself is aggressive. So you pass to sequential chemotherapy, the patients may not tolerate and they have a much worse prognosis. So this is the main story. So you have triple negative, you have chemotherapy, you have platinum, you have immunotherapy in a big way. But in spite of all these things, the responses and the overall survivals have been not more than 12 months or a year and a half at most of the study. So because there was some data looking at those patients who had a low HER2 expression having some benefit, you've tried to use trastuzumab in these patients and shown that trastuzumab is not enough. Adding trastuzumab did not make a survival difference in these patients, either in disease invasive disease-free survival or overall survival. So trastuzumab was not good enough for these patients who had a low hormonal expression, HER2 expression. You did have some studies looking at phase 2 study looking at adding pertuzumab in this subset of patients. Also, you have margetuximab in this relapsed refractory subset of patients. It still did not show you much of a benefit in this subset of patients. So there were a lot of basket trials that were done, and in which they saw that these drugs, which were antibody drug conjugates, which were more specifically designed to enter into the nucleus of these HER2 where you have now HER2 activity, did show some response, especially to those patients who had had disease progression post trastuzumab or pertuzumab. So they did show some responses, which is interesting to look at this point of time. So trastuzumab deruxtecan, as all of us know, the Destiny 4 study was a landmark study. It's an antibody drug conjugate, very similar to TDM1, where you have a drug attached to a payload, and the linker gets released when it enters into the cells. And the drug to antibody ratios is 8:1 is much higher. So it also has a bystander effect. Once it gets internalized into the cells, there's a cleavage, the linker is released, the topoisomerase inhibitor is released, and it causes the destruction of the cells, and it also causes the bystander effect, where the cells nearby also have are damaged as well. Now, this study was a phase 3 study looking at those patients who were HER2 low, which is defined as 1+, or if they were 2+, they had to be FISH negative and who had progressed post 1 to 2 lines of previous therapy in the metastatic setting, and they had to be considered endocrine refractory in the hormone positive subset. So this randomization was 2:1, and patients were randomized into one arm receiving testosterone deruxtecan at 5.4 mg per kg every 3 weeks versus the physician's choice of chemotherapy, which could be capecitabine, eribulin, gemcitabine, paclitaxel, nab-paclitaxel. Most of the patients were hormone positive. Almost 90% of the patients in this study were hormone positive, and the stratification was based on the previous lines of chemotherapy, the IHC expression as a central lab, and the presence of the previous exposure to CDK4/6 inhibitors in the past. The primary endpoint was the progression-free survival, and secondary endpoint is OS, the objective response rate, and the duration of response rate, the safety, and the patient-reported outcomes. So if you look at the study, if you look at the hormone receptor positive, which was a majority, the bulk of the patients were hormone positive. So the median ages were matched in both the arms. There were 30% each in both arms of Asian patients, and majority of the patients, like I said, was around 90% were hormone positive. Now, coming to the previous lines of chemotherapy, median lines of chemotherapy was at least 3 cycles, and if you look at endocrine therapy, the median line of endocrine therapy, which was patients were exposed, was at least 3 cycles. And at least 78% of the patients, or 80% of the patients in both the arms, had been exposed to CDK4/6 inhibitors. Now, if you look at the PFS in the hormone positive patients and all the subsets, like I said before, this study had a lot of patients who were hormone positive. So there was a bias towards the hormone positive subset. And what you would see here is that the median PFS was 10.1 months versus 5.4, almost double, with a very healthy hazard ratio and a good p-value. Now, if you look at all the subsets together, again, like I said before, because the hormone positive subsets were much higher in the study, the median PFS was only dented to a certain amount, with 9.9 months versus 5.1 months. Now, if you look at the OS, again, you can see the curve separating by around 6 months, and you can see that the updated analysis showed a median OS of 23 months versus 17 months. Again, very healthy hazard ratio of 0.69. And if you look at both the subsets together, it's again, like I said, 22.9 months versus 16.8 months. Now, if you look at the investigator-based analysis, so the other one was by the central review. The investigator analysis showed an updated analysis of PFS of 9.6 months versus 4.2, and with all the patients, it was 8.8 months versus 4.2. So if you look at these subsets, if you look at the hormone negative, and this was not a major, it's only around 40 patients in the testosterone deruxtecan arm and 18 in the chemotherapy arm. There also you would see that it is 17 months versus 8.3 months, but the study was not designed to look at the subset alone and as such. So this is one thing. Even in that subset, the PFS and the OS were much better than what you would expect. Now, coming to toxicity, as we have a new drug, we are always cautious. When trastuzumab came first, I remember as a postgraduate that the first time when we were starting using trastuzumab, everybody was very anxious. There was a time for the first 2-3 months where an echo was done every month because everybody was worried about the cardiac toxicity. Then slowly we matured to understand that it's not required to do it every month. So a drug like this, when it comes out, you're worried about the toxicities. And one of the main things that you need to understand toxicity is pneumonitis. You have drug-induced pneumonitis, which can be a problem at 8.2%. And if you are looking at chemotherapy, looking at 2.3% of sensory neuropathy. You would have some amount of alopecia, of fatigue or nausea, but the main thing that you're worried about is developing pneumonitis. So the patient's history of any previous interstitial lung disease, any of those things are very important when you start this patient on treatment. Because the signs could be subtle, the fever, the cough, all these things, you'll have to be ruling out everything and have a very high suspicion of index when you treat these patients with a drug like this. you need to immediately stop the therapy if you are suspecting a pneumonitis, because then it can lead to further problems. So other than the pneumonitis, most of the toxicities are very similar to your chemotherapy, even less at some point of time for most of the chemotherapy. And based on your toxicities, the dose discontinuations and dose interruptions were almost lesser than what you would expect with chemotherapy. But yes, pneumonitis is something that it is expected to happen. All grades would combine to around 12%. But majority of your patients would be grade 1 or grade 2. So it's important to pick it up much earlier than what you would expect. And then yes, like all your trastuzumab and your anti-HER2 therapy, you would have to monitor your cardiac function with this drug as well. So the Destiny-04 established that your trastuzumab deruxtecan is a new standard of care in low HER2 expressing breast cancer, especially in the hormone positive breast cancer. Those patients who have been exposed to endocrine therapy have disease progression post endocrine therapy, and especially when they've been exposed to CDK4/6 inhibitor. So that is a new thing, because it is going to have a meaningful survival for those patients who are already exposed to hormonal therapy and a CDK4/6 inhibitor. Now, this is what NCCN says. Yes, NCCN now approves trastuzumab deruxtecan in this subset of patients who have been already exposed, and would consider this as a main type of therapy for those patients who are low ERPR who have low HER2 expression and who are hormone positive, who have been exposed to hormonal therapy in the previous lines. Now, coming to a similar drug, which is again very interesting, is that I first heard about this drug in the triple negative subset. Again, it is based on your presence of your TROP2 protein, which is expressed in these patients with breast cancer, and you see that more in the triple negative subset. So you're trying to target even the triple negative subset now. So the ASCENT study looked at and showed that using sacituzumab govitecan had an improved survival against single agent chemotherapy of your choice in a triple negative subset, because this is one subset that is very difficult to treat. We have patients with this, and in India, we do have a high number of patients with this subset. And the median PFS was 4.8 months versus 1.7. And the median overall survival was 11.8 versus 6.9 months. So right now, it is now approved for those patients with metastatic triple negative breast cancer who have received 2 lines of prior chemotherapies, at least one in the metastatic setting. So this is again a monoclonal. It is an ADC, antibody drug conjugate. If you look at the study design, it again looked at those patients who had received at least 2 lines of chemotherapy in the advanced setting. And it is a randomization was 1:1, in one arm getting sacituzumab govitecan 10 mg per kg IV on day 1 and day 8 of a 21-day cycle, and the other arm getting the physician's choice of chemotherapy. Treatment, like in a metastatic setting, was continued till disease progression on unacceptable toxicity. And the primary endpoint was PFS, and the secondary endpoint was PFS in the intent to treat population, OS, and objective response rate. So what you would see in this subset of patients is that if those patients, again, they had looked at subset analysis of patients who were HER2 negative, that is 0% versus low. And what you would see is the median PFS in this subset of patients was, in the patients who were 0% was 4.3 versus 1.6. And in those patients who were low HER2 expression was 6.2 versus 2.9 months. Look at the overall survival again. It was 11.3 in the 0 HER2 IHC versus 5.9 months versus 14 and 8.6 months in the HER2 low subset. So what you would see is that we are going to go more beyond just the IHC of 1 plus 2 plus, and the fact that the more I understand this drug, that the competition right now would be on the best drug to look at the subset. Sacituzumab govitecan is now even approved for those patients who are, the FDA approved it for those patients based on the study of those patients who are hormone positive breast cancers as well. So as time goes by, we'll have to see which of them will be a better drug for this subset of patients who have a lower HER2 expression and who are hormone positive. Having said that, trastuzumab deruxtecan is here to stay. It is shown to be a superior drug than TDM1 in the metastatic setting. So if you have an option and the patient can afford post-progression of trastuzumab, it is going to be an effective drug if the patient can afford to use a drug like this. And in the hormone positive, post your exposure to your CDK4/6 inhibitors, and your patient has become endocrine resistant, you do have a therapy which is much more effective and slightly lesser toxicities as compared to standard chemotherapy. But you would expect toxicities in terms of ILD and cardiotoxicity, which we have to learn as we go ahead and use these drugs. So the future challenges is like I said before, we will really have to define what exactly is a low HER2 expression. We have to be aware. Right now, the biggest challenge that we face is that previously all our files we used to mark them as HER2 1 plus 2 plus. We never used to mark it like that. We used to mark it as HER2 negative. So now in my network that we are collecting data, we are going back and trying to find out all these patients who have 1 plus 2 plus, which we are calling HER2 negative. We are now trying to subclassify it, and I teach my postgraduates also the same thing, is that those just don't write HER2 negative. You rightly have to now say HER2 1 plus 2 plus, ER how many percent, PR how much percent, because that is how deep we'll be going in the few years to come. So your biopsy, your tissue handling, your processing, all these things are going to be very important. And like in everything in oncology, it is going to be a multi-modality treatment. So the important thing, what I would say at the end of the day, is that it's not just HER2 low. I know this is a pharma-driven thing, the HER2 low thing, but it is going to be expression at a lot of other molecules. And like I said, low ER, PR, the percentage of expression, all of them are going to be important. So it is important that you classify your patients, collect your data, and work towards a better future. So with that, I would end my talk and open the panel for discussion. Thank you.
Well, thank you, Dr. Ashwin. You have raised a very valid point that since you have a molecule for which is actually a very wonderful molecule with a good bystander effect, that you are now thinking in terms of HR1 plus and HR2 plus, and even there have been studies that this particular molecule is even effective in HR0. So how the driver mutation dynamics are changing, that will be a very interesting thing to look after. So we'll take now the thing is, with the advent of this molecule, though the access in our country is limited because of the financial constraints, despite the data we have. So, how do we sequence our therapies? What is the ideal way? Dr. Devinder had shown that if you have a HER2 positive breast cancer, metastatic breast cancer, you should do this thing. And second line, you should do this thing. And third line, you have these options. What do we do in India? That is a very important question. So let's thrash out these things through a case discussion. So I would like to invite my panelists. I can see Priyanshu. Rest of my panelists, please switch on your cameras. Dr. Piyush Mehta, is Piyush there? Piyush, please तनिक खिड़की खोलिए. Dr. Nitish Garg, I can see Nitish ever smiling, and Dr. Imran Khan. I have Imran.
Yes, sir, I'm here.
Okay, I thought you were bowling somewhere. Okay, the Dr. Keshav Garg. Dr. Keshav Garg. I can see Dr. Keshav Garg. Anyways, guys, should we go to the case straight away? I think
Sure.
we have had a very long session. Uh, uh, Dr. Keshav Garg, is Dr. Keshav Garg here?
Yes, sir. I'm here.
Okay, welcome. So, can I share my screen?
Sure, sir.
Mm. Okay. Well, this is a hypothetical case given to me just for the purpose of discussion. Okay. Is my screen visible?
Yes, sir.
Yeah, fine. Okay, so the objective of this discussion is basically choosing the right therapy for a patient. HER2 testing in MBC, we have heard a lot about all these things. Managing brain metastasis in HER2 positive breast cancer, and the most important being treatment sequencing in the era of newer targeted therapies. So we had this 55-year-old postmenopausal female who had a clinically T2N1 disease, ERPR negative, HER2 positive. She received neoadjuvant TCHP, underwent surgery. She didn't have a PATH CR. So after adjuvant RT, she got TDM1, and she had no comorbidities. She was fit postmenopausal females. Unfortunately, after 2 years of completion of adjuvant therapy, she complained of mild cough and back pain. And PET-CT was done, which revealed multiple lesions in spine, pelvis, and several pulmonary nodules. ECOG performance status was 1. So I have these questions. We'll take it one by one. All the panelists, will you re-biopsy? You can
Definitely,
answer.
sir.
Definitely. All of you will re-biopsy.
Yes.
100%. So we don't have
Rebiopsy.
we don't have any discussion about this first question, right? So let's go to the thing. The patient was biopsy from the biopsy portion, that is lung nodule, and she was now HER2 2 plus and fish positive. Now, after 2 years without any CNS symptoms, she is HER2 positive breast cancer. Who is doing, who is evaluating brain before going for therapy? Before going to next line of therapy, who among my panelists is going for evaluation of brain?
Yes, brain
Sir,
MRI should be done in all HER2 positive breast cancers because 50% of patients do have some brain mets. This subtype has, it is notorious for brain mets. Brain MRI should be done in metastatic setting on progression. And
Yes.
given PET-CT is only PET-CT has been done, so MRI is required.
Okay. My other panelists?
so I think if the patient is not symptomatic, we can observe the patient for the symptoms. And the PET-CT can, though it is not very specific for the brain metastasis, but still it can tell us give us some idea if there are some doubtful lesions in the brain. And if the patient is totally asymptomatic, I think we can avoid it. If at advent of any episode of any headache, vomiting, or episode of seizure, we can think of doing the MRI. So
So
as sir has
you will
rightly
do it
pointed,
when, if the patient is symptomatic, you will evaluate brain.
yes.
Okay. Piyush, you are pretty silent. Are you there?
Yes, sir, I'm there.
Okay.
Yes, sir, definitely. Sir, we'll do MRI because HER2 positive disease, so high chance for brain mets, sir.
Right. Priyanshu, what do you think?
Practically, I see the PET report first. A large lesion usually is picked up, although it's not a gold standard. I'm telling you what I do practically. And asymptomatic, I usually don't go for an MRI, even in HER2 or even in triple negative. This is what I do in practice
Okay.
because I don't think so that would change my treatment process.
Okay. Okay. Keshav,
Yes, sir. So in asymptomatic patients, we don't do MRI brain test. And if patient is symptomatic, then we definitely do. Otherwise, we straight away start with the PET scan.
suppose in PET scan you find that the disease is controlled everywhere, and you have a small brain met, but patient is stable, patient is asymptomatic. Or let me frame the question this way: how many times have you found on progression in a PET scan presence of small asymptomatic brain mets? Sometimes with even with evaluation MRI, we are not able to characterize those mets. How many times have you found in HER2 positive breast cancer? Uh,
Sir, should I take the question?
yeah.
Sir, it is, I don't know about the rest of the panelists, but it is a frequent occurrence. Our HER2 positive metastatic usually have some asymptomatic silent brain mets. What I have
Okay.
seen in my practice. So it is a standard practice in our like in our institute that we do a screening MR in all patients.
I would agree with you because over a period of time, even in my practice, I have seen that I am more and more evaluating even asymptomatic patient for brain mets because I have burnt my fingers in some cases. So I agree with going for brain evaluation. Anyways, any role of for NGS? Practically anybody is doing NGS or any role as such. Would NGS help at this point of time?
I think we have a driver, and that is HER2, which is driving the disease. So as of now, and we have enough number of therapies available. So either if the patient is willing, yes, we can do it. We can give them an option. Otherwise, it is not going to change our treatment approach.
Exactly. So, do you think NGS at this point of any of my panelists would change the treatment approach?
I don't think so.
I don't think in the majority it won't change. So we don't do NGS. Now, suppose in this very particular case you have HER2 0 on IHC. Or let's say HER2 1 plus. So, what will be your treatment choice? Would you use anti-HER2 antibody?
Can I take it, sir?
Yeah, sure, Nitin.
So HER2 0 will label it as triple negative, sir. There comes the role of NGS plus PDL1 testing. And if it is HER2 1 plus, and then I'll still get a FISH done. If it is FISH negative, so then we can still think of going ahead as a TDXT, using TDXT with low HER2 approach. So
So,
again, in HER2 to 1 plus or 2 plus with FISH negative, the approach remains the same. In HER2 0, the approach
so
might
in
change.
HER2
No,
1
but
plus, yeah,
in this
Priyanka.
line, so in this line, it's still not indicated. I mean, within 6 months, it's approved. If it lapses after adjuvant or neoadjuvant therapy within 6 months. But with a DFS of 2 years, I don't think so. TDXT would be approved in this indication, even if it's HER2 1 plus.
With the, you mean to say with such a long DFS,
And sir,
TDX?
I don't think so. The trial used FISH with the 1 plus. They used in 2 plus, if I'm not wrong.
Yeah.
They had 1
No.
plus FISH negative and 2 plus FISH negative.
So, TDXD can always be used whether a long or a short DFS. But
Okay.
yes, I totally agree that 1 plus we won't be using fish. That is the thing. We won't be using the fish. Anyways, so there can be a very long discussion. So what is the treatment of choice in this particular patient? Start from, okay, Nitish, you start. These are the options available. And let's suppose TDXD is also available.
So I think first of all TDXT, sir.
Hmm.
If patient is not willing or for some financial issues, maybe trastuzumab plus taxane as a single anti-HER2 combination or a dual anti-HER2, but she has already progressed. So that is a dicey scenario to use. TDM1 has already been given. So I feel best bet for us will be TDXT. If not, then re-challenging trastuzumab, pertuzumab plus a taxane.
Re-challenging trastuzumab, pertuzumab, and docetaxel.
Yes.
Imran.
Sorry, I missed a bit. Is it in first line? In first line, it is trastuzumab, but on
No, no, no.
recurrence,
It is a recurrence after 2 years.
after 2 years and no first line, we should use trastuzumab, double anti-HER2 along with taxane as first line. TDXT is second line treatment. If a patient has progressed on recurrence,
Okay.
giving trastuzumab, then we have to TDXT. It is
Priyanshu.
not as of yet. It's not good first line recurrence or metastatic first line setting.
Dr. Priyanshu.
So again, options are both. I mean, usually before the advent of TDXT, early relapse, probably less than 12 months, we used to use TDM1, and after that, we used to re-challenge with pertuzumab, trastuzumab, and taxane. Sorry. So I will still go ahead with pertu, trastu, and taxane, and TDXT later on probably.
Dr. Keshav.
I would like to go with trastuzumab plus pertuzumab plus taxane in first line. And as DFS was 2 years, if it has to be less than 12 months or 6 months, then definitely TDX.
Okay. And finally, Piyush. Piyush, what will be your choice of drug?
Sir, TDXD in this patient.
TDXD in this patient. Okay. So people who opted for trastuzumab, pertuzumab, and taxane, have you read Cleopatra? What was the eligibility criteria for Cleopatra? What was the eligibility criteria for Cleopatra? Pertuzumab was not used in those patients. TDM1 was not used in those patients. So, do you think trastuzumab, pertuzumab, taxane would work in patients who have progressed? It was actually an exclusion, rather. I mean, pertuzumab actually came and it was given in that era when we used to have only trastuzumab. So, has there been any study in which re-challenge has had a significant benefit? Anybody? I mean, let it be a very lively discussion. I mean, because this is a very, very practical scenario. And suppose, let's say, this patient has a brain metastasis. Now, what will be the choice of your agent? Let's say, let me present the case, and there is a stable brain met. Patient is asymptomatic. How will you manage? Let's start with Keshav.
If patient is having asymptomatic brain met, and then although I won't change the systemic therapeutic option. Although in Cleopatra, fewer number of patients receive adjuvant or neoadjuvant trastuzumab, but we can re-challenge if there is good DFS after the neoadjuvant or adjuvant.
No, if there is brain mets, then would you use trastuzumab, pertuzumab, taxane?
Actually, Nirap will be a good choice in that patient, but we don't have that option. Otherwise, we can use TDX in that patient.
Okay, Priyanshu, if you have a brain metastasis, stable brain metastasis, what will be your choice?
It's the same. Right now, I would still be convinced with the same.
No, you have a TDXD at your hand.
Stable, single metastasis, probably I would still save TDXT for later lines. But yes, if you have multiple.
So you people are still
symptomatic.
convinced that trastuzumab will have a good amount of benefit in this patient.
The penetration will be poor in the brain. I think we should be thinking about TDXT. If the systemic disease responds well, the brain is going to
And
explode with that
without brain
metastasis.
metastasis, you feel that this is a very good combination. Without brain
I feel
metastasis,
TDXT.
without brain metastasis also, do you think this was the population in which Cleopatra study was conducted? It was a de novo. It was a de novo case. They were all de novo cases, as far as I remember. Correct me if I'm wrong. Okay, let's say TDXD is not available.
TDM1 will
Let's
be
say,
a better choice.
yeah, which one?
TDM1 will be a better choice in brain met.
TDM1 will be a better choice in brain metastasis. Okay.
Sir, may I come?
Yeah, sure, Imran, please.
Sir, with respect to the Indian scenario, we have LAP and CAP. That is all we give. So lapatinib has some brain penetration. That's all that we are giving to the patients. Now your question is, sir, in stable brain mets, if it is first line, as of now we don't have data from Destiny trials that first line we can give that. In second line, yes, for brain mets we can use them. Otherwise, if there is active brain mets, then tucatinib. How to climb study has shown that active brain mets, tucatinib has given a better PFS. But with respect to these subgroup analysis of Destiny Breast Trial 3, the Tuxedo trial and the other Debra trial, they have shown that for brain mets, TXD has also a good, they have shown, they have produced their better numbers with respect to the overall response rate, PFS rate. So somewhere down the line, we are a bit confused. What should we use in patients of brain mets with HER2 positive? Because they are very notorious for going to the brain. So as of now, since the sequence of where ultimately our discussion is boiling down towards the sequencing of the drugs. So I think the first line treatment in any case should be trastuzumab with pertuzumab taxane. Then pertuzumab, it is a point of discussion whether we should re-challenge depending upon clinical scenario. Because what we usually do in our daily day-to-day, we don't usually follow the trial design. Although the trial design has shown de novo meds, but depending upon the scenario, we can add. And pertuzumab on any day is a bigger, costlier molecule. I don't know how much a patient will be convinced of using Perjeta. So second line, as of now, it is TDXD. So TDXD should be a second molecule. Even if patient is having brain mets, we should use there. And after that, I think third line, as per NCCN guideline, is also there. The third line we have to use in tucatinib. But I think our job is a bit less confusing because we don't have these molecules, we don't have tucatinib available. So we have a better sequencing. Use trastuzumab in first line. If patient is
Yeah.
progressing, then use TDXT in the second line. Again, in TS first line, maybe depending on the clinical scenario, as one of my colleague has said, that if there is a single lesion, we can always try for a local radiation SRS based therapy and see the patients. So this is how we should go ahead, I think.
Yeah, you have summed up really well. Actually, the thing is, our job is not easier. Our job is really tougher because of the constraint, and we all are doing a wonderful job sailing on in the same boat. It is just a matter of discussion that what should we do. And this patient, yeah, this is the Cleopatra study. Yes, we all know the data of Cleopatra. And so she was given a THP, and she had a good response, and she was also given rank ligand inhibitor. So very strangely, I don't think this is a very common scenario. Very strangely, she had a disease control for at least 18 months. So after 18 months, she developed dry cough, progressive bone disease, and multiple new liver nodules. So now what? Now what? One by one. Now what? Now what should be the
As
TDXT.
per
yeah, Nitish, please.
yes, sir, TDXT. So if she has already received a rechannel with TCA,
Uh-huh.
THP, TDXT should be the next option.
Okay. Where's Priyanshu? Priyanshu, now what? We are given THP and
Now TDXT, sir.
okay,
Now to
okay. So everybody agrees on TDXT. Imran?
Yes, I agree. If patient
Okay.
doesn't have financial constraints, we should go ahead.
So that is the ideal scenario. So what will you do in practical scenario? So somehow he took Parjeta. Okay, and now he has failed. Or she has failed, not he. She has failed. Now what? In Indian scenario.
Lapatinib capecitabine in combination, plus minus trastuzumab.
can try for generic TDM1 if they can afford that. Uh, Although
Okay.
again, we will say that when TDM1 was launched, there were very few cases where received pertuzumab in Amelia or Theresa. Probably must be very less. But still, I think so. That is the best bet we can have. Uh,
But she has already received TDM1 in the adjuvant setting. So don't
she
you
had
think it
already
is not
received pertuzumab also.
also? Yes,
She
yes,
has
but
Yes,
received
yes, yes.
so the
pertuzumab
scenario has
also.
already changed. That was the exclusion there, which was
So
keeping
pertuzumab,
my
pertuzumab, given pertuzumab or given a even long-term trastuzumab also. TDM1. I am bit skeptical in TDM1 usage. TDXT is the totally different molecule we all know, and if given a choice, we would really use it. But TDM1 lab cap, yes, poor man's thing. And what do you think about? Suppose this patient also was ER positive. Do you think there is any role of adding CDK4/6 inhibitors in these?
Yes, there are some phase 2 trials which have used
Abemaciclib.
CDK4 inhibitors with hormone therapy and trastuzumab.
but
Monarch
that
HER2
driver.
trial is there, no?
Yeah,
Yes,
there is.
Abhi,
Yeah, please.
Monarch. So
Monarch
Monarch trial.
Monarch trial is there, and then recently Aspire trial is there, in which fulvestrant with palbociclib and trastuzumab has been studies, and they are pretty good, but provided the patient is HR positive. There is always an escape mechanism. When you keep on attacking one driver mutation, there is always an escape mechanism. The easy escape is hormone receptor positivity.
So
So
then,
yes,
why
yeah,
not here we get a repeat biopsy done and go for NGS testing?
perfect, perfect. Please go ahead. But people who cannot afford TDXD sometimes don't even afford NGS. So
Yes.
the thing is,
But
we
what are we searching for in NGS? I mean, what is the
We are
targetable
just
mutation which we are searching?
see HER2 will be the main target because we always know HER2 is the main driver in the usual HER2
no,
positive disease.
HER2 is
But
still
there will be
positive.
some, yes, there will be some resistant mechanism which we can find out that this mutation is the cause of the resistance to
But
HER2.
can we do something about that resistant mechanism? That is the thing, no?
So that is always a discussion for NGS that
No,
we
no.
can.
Can we do something for HER2 mutation? Yes. Again, you have only one molecule, that is TDXD. Or there are newer molecules which are not available in India as yet. Anyways, so which treatment do you recommend? I think we all agree that TDXD is one of the best if available. Rest, there could be umpteen choices depending upon the case scenario, patient's affordability, and how she has responded to previous treatments. practically we all do in this way. So Destiny Breast 03 has been discussed, and TDXD, whether you use pertuzumab or not use pertuzumab, it is effective. So anyway, I think we won't stretch this thing too long. And this is that data of her to climb and Destiny 03. But the difference is that Destiny 03 was studied after 2 median lines of therapy, and this was tucatinib was studied after 3 lines of therapy. So, and the important thing, we were just reviewing the paper in the morning also, that these two molecules, tucatinib and in tucatinib specifically in combination, and trastuzumab deruxtecan, they are having some activity against active brain metastasis also. So that is a important thing. Just want to conclude, because we have already been into so many things. So I would say, so final question to all of you: who all have used Enhertu?
Sir, in our past center, we had a trial of Destiny going on, so I have some experience in trial based, but in real world, I have yet to use it. So,
Okay,
but I have
so how was
ILD.
your
So
experience? I
ILD
mean,
definitely, yes, sir, yes, sir. ILD, we had a elderly female, metastatic breast cancer, HER2 positive only. She definitely developed ILD after 3 cycles. So we have to go a dosage reduction in that patient.
okay,
So
so what was
ILD,
the dose reduction you did?
so
How much?
this is conventional. I think 5.4 to 4.8. If I remember, it was
Oh,
conventional because in trial we cannot modify by ourselves. It is as per the trial. This enrollment as per that we have to go follow. So ILD, I have seen patients, they do develop, and it's a very problematic thing.
so it was a grade 1 or 2 ILD.
I think it was grade
That's
2,
why you
grade 2.
did dose reduction, no? Otherwise,
Yes,
then.
yes, yes, sir, yes, sir. It was grade 2, around grade 1, grade 2, and she required some. Yes.
Okay. Priyanshu, you have used TDXD?
Yes, I've used in one patient. Unfortunately, she died of some other causes, pneumonia. So after 2 doses, and clinically there was a response because she had skin nodules and all that, which disappeared after even the first cycle. But unfortunately, we didn't have any PET or something like that. And
Okay.
she had a cardiomyopathy already, so multiple
Mm.
comorbidities. Only one patient I've used.
Okay. Anybody else? Anybody else who have used TDXD?
No.
Oh, fine. So now with the availability in India, maybe more and more patients will be, but it will be a learning curve for us. Like as Ashwin was saying, that it was a learning curve even when the trastuzumab came. So ILD, as we were discussing in the morning also, me and Priyanshu, that ILD is actually a class side effect of anti-HER2 agent. Varying intensities in different anti-HER2 agents of ILD is seen. Even in Destiny 03, when TDM1 and TDXD were compared, you could see that the both the agents had some amount of ILD, though it was more in TDXD arm as compared to TDM1 arm. So I would just say that wonderful drug, more and more access or more and more availability would lead us to use this drug. And maybe the sequence of treatment is going to change a lot, and this drug won't be limited to just HER2 positive. With the data in HER2 low coming, it will be used in even HR positive and even triple negative breast cancer, as everybody has now started writing HR 1 plus, HR 2 plus, rather than simply HR negative. So, with that, I would invite any other comment from any of the panelists or speaker if they are there. Anybody who wants to say something. So if no one has anything to say further, I would like to thank the sponsors of this meeting. Thank you all, and I think we have some fruitful discussion in the upcoming stratification of breast cancer. And two important, I would say, drugs in the armamentarium of management of breast cancer have been in the past decade are antibody drug conjugate in HER2 positive and CDK4/6 inhibitors in ER positive. So we all agree with that, and there are plethora of agents which are coming, the plethora of resistant mechanism which are being identified, and maybe 10 years down the line we would see this TDXD moving at place where TDM1 is now. There are trials going on to use TDXD, because in Catherine study we had the long-term data shows that people used to fail in, or females used to fail in the brain. So there has been a study in which tucatinib with TDM1 is added as a maintenance. So maybe in future TDXD will be coming as compared to TDM1 after new adjuvant when PATCR is not achieved. So there will be many new things coming up, and the whole scenario may totally change in future, and the future is pretty exciting. But till then, we have to work under our constraints. I would say let us be very careful in reading the data, and because whatever we have, they are pretty expensive molecules. We have to judiciously use them. And thank you very much. And I hand over back to the organizers.
Thank you, Dr. Jatin sir, and all the esteemed faculties for this informative webinar. And thank you all the pharma persons for the supportive and making this webinar successful. Okay, Jatin sir.
Thank
Good
you.
night. Good
Thank
night,
you.
everyone.
Thank you, everyone, and good night, everyone.